Welcome to this episode of the Pediatric Intensive Care Awareness Week podcast series, which is run by the World Federation of Pediatric Intensive Care Society. In this series, teams from different global regions share their experience with a special focus on how technology and innovation can help to improve the care of critically ill children. My name is Hans-Jörg Lang. I'm working for the Heidelberg Institute of Global Health and the humanitarian organization ALIMA. It's an honor for me to host today's conversation, which highlights the remarkable efforts of clinical teams working in Sub-Saharan Africa. I would like to welcome Mrs. Mara Hisiatu, a senior nurse and matron working at the Oladuring Children's Hospital in Freetown, Sierra Leone, West Africa. We also have Prof. Archipe Birinwa. He is a senior pediatrician working on a pediatric unit in Bukavu, South Kivu, in the east of the Democratic Republic of the Congo. We also have Prof. Diavolana Andriana Rimanana, a senior pediatrician and hospital director of the Centre Hospitalier Universitaire Mahajanga in Madagascar. So welcome to you, Diavolana. In this podcast, our colleagues will share their challenges they face in their countries and within their working environments. But more importantly, we aim to highlight their resilience, courage, and professional expertise, as well as their remarkable potential for innovation and problem-solving capacity. Before we start, some background information. Despite considerable advances in global child health, in 2023, still more than 4.8 million children died before the age of 5 years. Many of these tragic losses resulted from severe infections like respiratory infections, severe malaria, diarrheal diseases, sepsis. Most of these deaths or conditions are preventable and or treatable. In addition, a large number of these under 5 deaths are linked to undernutrition, and around 40% of them occur in the neonatal period. Importantly, maternal health is critical for disability-free neonatal survival. Yet, maternal morbidity and mortality remain unacceptably high in many resource-limited settings. Most maternal deaths are preventable and treatable, for example, caused by severe infections, sepsis, postpartum hemorrhage. This also underscores the need to integrate reproductive health into essential critical care approaches, including a strong focus on adolescent health. Globally, around 1.5 million children and young people between the age 5 and 19 years died in the year 2023. Causes, again, are severe infections, but also injuries like road traffic accidents, exposure to violence and conflict. Important causes of morbidity and mortality in this age group are also communicable diseases, sickle cell disease, HIV, TB. Children and young people in low-resource settings face exceptionally high mortality risks due to socioeconomic challenges and humanitarian crises. The African continent in this context bears a disproportionate burden of disease. While improving living conditions and public health measures, like vaccinations, malaria prevention, access to essential emergency and critical care is another important element of improving child health. Strengthening referral pathways from communities to peripheral health facilities to district, regional hospitals plays an important role in this context. Some regions across Africa confront additional dramatic challenges, such as ongoing health emergencies. As an example, Eastern Congo is currently experiencing an mpox epidemic, while being exposed as well to the impacts of conflicts and a large number of internally displaced populations, particularly in the provinces South Kivu and North Kivu. In Sierra Leone, for instance, the impacts of the civil war over 2 decades ago, along with the devastating effects of Ebola outbreak between 2014 and 16, still shapes both the health system and socioeconomic conditions. In many countries, climate change further compounds these challenges. Example, in Madagascar, the country is facing increasing frequency and severity of tropical storms, altered rainfall patterns, and threats to food security and infrastructure. Addressing these complex challenges requires multi-sectoral approaches to mitigate, respond to, and prepare for the diverse threats facing the regions. In this podcast series, we will focus on access to essential pediatric critical care services, an important component of universal healthcare coverage as outlined by the United Nations Sustainable Development Goals. We are delighted to welcome our colleagues today. First, Sister Mara Hisiatu from Freetown, Sierra Leone. Dr. Archipe Birinba from Bukavu in South Kivu Province, Democratic Republic of Congo. And Professor Diavolana Andriana Rimanana from Mahajanga, northwestern Madagascar. Thank you all for joining us. Let's start in Freetown, Sierra Leone. Sister Mara, could you please describe the current situation in Sierra Leone and share some of the key challenges you and your team face in providing essential critical care for sick children in an urban setting in West Africa? So over to you, Sister Mara.
Thank you very much, Hans. Actually, despite the war we had 20 years ago, and after that, in 2014 and to 2016, we had the Ebola outbreak. We have been managing actually to provide essential services, especially to our critically ill kids. However, we have challenges. Since the Free Healthcare Initiative was launched in 2010, we had high influx of cases visiting our facility to access care. And to just give some few statistics, in 2023, we had well over 18,000 cases visiting our facility. And among these, we had inpatient admission of well over 13,000. And in 2024, there was an increase, and we had well over 24,000 cases visiting our facility. And among these 24,000, we have well over 14,000 cases being admitted. And actually this year, from 31st of March to the 1st of April, around 8 a.m. to 4 p.m., we've seen well over 100 cases, children. And among these 100 children seen, we had 25 being admitted and 75 seen as an outpatient cases and then sent home. Actually, due to this high influx of cases needing emergency care, our staff are in most of the time burnout and they are psychologically stressed. And most of these cases present with infectious diseases like malaria, pneumonia, malnutrition, and then sepsis. So these are our challenges for now.
You also mentioned that your unit in Freetown also had some infrastructure challenges, like electricity supply. Can you give us some more details, and how did that affect the care of critically ill children?
Yeah, before this time, our facility was getting a power supply from the national supply system. But there are some challenges with that, especially when we have critically ill children on oxygen, CPAP, and those monitors, etc. So due to these challenges, the MOHS, in collaboration with partners, brought the ideology of using a generator. And so they procured generator. Because the generator is operating on a daily basis, so there are issues with maintenance, there are issues with breakdown. So, but however, we are so happy now. We have 24-hour supply of electricity using the solarized system that we are now using.
So that's very interesting that stabilizing your electricity system can then obviously improve quality of care, especially if it comes to reliable oxygen supply, function of other biomedical equipment. You mentioned that you receive a large number of children from Freetown, but even maybe from upcountry.
Yeah.
Can you tell us a bit more about the challenges that families or parents of critically ill children face in an urban setting like Freetown when trying to access healthcare for their critically ill children?
Yeah. Freetown, of course, is the urban setting. And we have cases coming from the far east. Although the hospital is situated in the eastern end of Freetown, we have also cases coming from the far west with speed cases. And at times, we have traffic jam due to the road network. And there are difficulties. They face a lot of difficulty, especially when children are critically ill and need emergency intervention. So most of these cases, by the time they arrive at the hospital, is a problem. So even those also that are coming from the districts, from the rural setting, being that is the national, we are operating. I am in the National Hospital for Pediatric. By then it was the only referral hospital, but now we have one now that has been recently constructed. So we have also cases trying to access this facility from the rural setting also has challenges with transportation issue, and then the distance coming from the far rural setting to the urban setting in Freetown in order to access care. So at times, most of these children, by the time they arrive, is a problem.
So this is very interesting for our listeners. So usually, if parents try to access a health center or district hospital, or even the larger urban health facilities, parents will have to organize their own transport. There may be traffic jams, and there's cost for the transport. Sister Mara, do you have an ambulance system? And can you tell us a bit more about what works well and what are the challenges with the ambulance system in Sierra Leone?
For the ambulance system now, because of this issue we had with the road network, referral system, so now we have NEMS that is managing the ambulance system in order to convey critically ill children within Freetown, which is the capital city, and even from the district hospitals. Before this time, they had challenges like with the issue of saying fueling and other things. But for now, as recently as of yesterday and last week, the issue of fuel now is a bit better.
Thank you very much, Sister Mara. So now let's move to Bukavu in the Democratic Republic of Congo. Dr. Archipe, we are very glad that you can join us from South Kivu, the eastern part of DRC, of Congo. Could you describe the current situation in eastern Congo, in South Kivu? What are the main challenges you and your team are facing at the moment? So please, over to you, Dr. Archipe.
Thank you very much, Dr. As, for this opportunity. Of course, I'm one of doctors in the South Kivu province. I'm a pediatrician working in Bukavu, in the South Kivu province, in the eastern part of the Democratic Republic of Congo. Bukavu, as you know, is also the home of the Nobel Prize, Dr. Mukwege, a gynecologist who works at Panzi. As you know, the South Kivu is one of the provinces that is facing to the war. However, the health system in our province is under immense strain. Even before the current crisis, we were already dealing with very high children and maternal mortality rate due to the limited access to the essential health service and a fragile infrastructure. Now we are facing multiple overlapping emergencies. The first, there is the outbreak of mpox, which has been affecting a large part of the Democratic Republic and neighboring countries. In addition, over the past year, several areas in Ituri, North Kivu, and other places, we had the Ebola virus outbreak, and now we have had also some epidemic like Marburg virus near us here in Rwanda. And on top of this, we are exposed to an armed conflict. The resurgence of the M23 rebel movement has led to massive displacement of people, violence, sexual violence, and serious human rights violation. Thousands of people have been forced to flee their homes. Many arrived injured, traumatized, and urgent need of care. We are seeing many critical ill children, men with severe respiratory infection, severe diarrhea, severe malaria, sepsis, and malnutrition as a complicating factor. Recently, we treated children with measles, very concerning, as this could mean that vaccination cover among vulnerable population is insufficient. Our pediatric teams also care for children with mpox infections. Many of these children can become critical ill with respiratory complication like shock also and dehydration and bacterial infections. Especially malnourished children can develop severe mpox disease. Many patients are left with some complication like ophthalmology problems, skin lesion. We also treat in our hospital newborn infected with mpox. All of these very sick children need essential pediatric critical care measures such as supplemental oxygen and non-invasive respiratory support like bubble CPAP and other kind of treatment like for the shock, for severe anemia, and other neurologic complications. And we had also a high number of injured children, adolescents, and mothers care that need surgery because of the war, as you know. And here the big problem is to access to oxygen, ventilation, and also the blood transfusions. Just recently, I had personal experience that relate to that really shocked me. I was leaving to a meeting when two bombs exploded near an ambulance in Bukavu center, and I was just across the place. We suddenly had around 20, a dozen of wounded patients. I was obliged to remove the bed in the ambulance and to put patients inside in order to bring them to the hospital. That was very, very tough. That's the situation in eastern part of the Democratic Republic of Congo for now.
It's remarkable to hear about the incredible work you and your clinical team are doing to provide regular healthcare for sick children, all while managing an ongoing mpox epidemic. On top of this, there's armed conflict in South Kivu with a large number of internally displaced populations. Now, let's move to Madagascar. Prof. Diavolana, could you please explain the particular challenges and situations you are facing in your country regarding the care of critically ill children? So please, over to you, Dia.
Thank you, Hans. I am Diavolana Kesha. I'm a pediatrician and I work at the University Hospital in Madagascar, off the eastern coast of Africa. Madagascar is one of the fourth biggest island in the world. And today, in 2024-25, we are 31 million people. Despite considerable improvement over the last years, our child and maternal mortality rates is still relatively high. So there is challenges. There are solutions that were put in place, but the one of our challenges is that our country has a big island. It's not easy for the long distances, but separate homes from health centers, especially during a cyclone, so during the rainy season, because we have thousands of cyclones every year, and this is a challenge because there are damaging our infrastructure, the road infrastructure. Every year we have to build again, and especially for a hospital infrastructure. And the Ministry of Health.
Can you tell us more about difficulties of populations in Madagascar to access healthcare for critically ill children?
For the access for healthcare for severe ill children is beginning with the transport. Even the Ministry of Health put in place an ambulance system because now we have in each district an ambulance. For transport is difficult in rainy season because of climate change impact, bringing every year dozens of stronger cyclones, and these cyclones are on one way they are damaging the roads, difficult the access for severe ill children to the infrastructure. But on the other hand, there is also the cyclone damaging the health infrastructure, and it is every year. And unfortunately, we see that with the climate change problem, the cyclones are getting stronger every year.
Can you describe some other challenges Madagascar is facing in relation to climate change related events?
We are facing a drought. It's like on the east side of the country, on the coast of the Indian Ocean, there is this rain bringing diseases like diarrhea and malaria. But on the other hand, in the southwest of Madagascar, we have drought. So long time, no rain, and this has an impact on agriculture and food safety for the children, so that we have malnourished children. And when we are getting ill, especially in the southwestern or Madagascar, we have not this malnutrition have an impact on the critically ill children.
Yeah, thank you very much, Diavolana. And I know that you recently published a paper in the British Medical Journal regarding increasing numbers of HIV infections in Madagascar. Can you tell us briefly something about this emerging problem in Madagascar?
This is an emerging problem in Madagascar because, during the COVID-19, every program was a little bit suffering because all effort was with COVID. But it's after the epidemic that we saw the rise of HIV cases. And this is seen especially in the in the southwest region, as there was a systematic HIV testing in the children suffering malnutrition. And this is a more challenge for the country.
So thank you very much, Prof. Diavolana, for this important information. So as we have heard, Madagascar, similar to what has been shared by colleagues from Sierra Leone and the Democratic Republic of Congo, faces considerable health system challenges, which often make it difficult for families to access essential critical care. In addition, Prof. Diavolana also highlighted how climate change-related events are having a severe impact on the population's living conditions, food security, as well as road and health system infrastructure. We also heard worrying rise in new HIV infections in Madagascar, particularly among young people, with growing implications for mother-to-child transmission. So all this highlights the need for international solidarity, fair economic systems that allow countries like Madagascar and Sierra Leone and Congo to invest in stronger health systems. Sustained funding of UN agencies like WHO is also important to support resilience, capacity building, and epidemic preparedness. Importantly, implementing climate change adaptation measures requires significant funding, especially for countries that are severely affected by climate change and yet have historically contributed minimally to global carbon emissions and other environmental stresses. Under the framework such as the European Green Deal and international climate negotiations, industrialized countries have a responsibility to provide substantial support to vulnerable countries. Now, let's return to Sierra Leone. Sister Mara, could you please share with us some of your team's problem solution approaches? We would like to hear more about your training programs, both at undergraduate and postgraduate level. So over to you, please, Sister Mara.
So actually, a significant initiative has been taken to enhance pediatric healthcare through innovative programs like the specialized training program for nurses and doctors. So the doctors, we have a pediatric training program in country, and it was initiated by partners 5 years ago in order to reduce on our child and infant mortality. Also, for the nursing training program, we have the post-basic neonatal nursing program, also initiated by one of our partners in collaboration with Ministry of Health, which is actually a one-year program that is specifically for nurses working at the special care baby unit across Sierra Leone. So the first cohort graduated, and actually 21 nurses graduated, and they were selected from regional hospitals. And the next cohort was from district hospital. Hopefully the third cohort also will be selected, and they will start the training again in May. So also there is the emergency triage and assessment and treatment training program certified by WHO, and that one also, when nurses are being trained in order how to exactly know how to care for emergency cases accessing our facility, and to be able to track them well and then intervene immediately.
Sister Mara, this is very important. So you mentioned the WHO recommended ETAT training, emergency triage, assessment, and treatment.
Yeah.
Interestingly, Sierra Leone decided to adapt the ETAT training to the specific needs in your country. Can you tell us a bit more about the additions you made to ETAT, like your pediatric critical care training program?
Yeah, so ETAT is actually a life-saving training that was done for nurses. And because most of the cases accessing our facility, they come with them critically ill. Most of them are emergency cases. So that one was done for nurses, and they were top-notch in terms of actually attending to emergency cases and stabilizing them. So when they were stabilized at the emergency department, in order for us to create room for other emergency cases coming in, we send them to either the pediatric intensive care unit based on their conditions, or the high dependency unit. Nurses were trained on how to use the different equipment there to care for these cases based on their condition. Yeah. So by then, and since then, we are able now to actually discharge more cases, despite they come in with emergency cases. One, we use the ETAT approach, certified by WHO, to stabilize and then send to the critically ill wards for continuum of care by these critically ill nurses that were trained. We had nurses. First, the criteria for you to be trained on care of the critically ill child is that you should have done ETAT. So that is one of the criteria. There is no way you can be choosing as a nurse to undergo the CCC training, which is the care of the critically ill child training, without doing the emergency triage and assessment and treatment training. So we have nurses now that are actually catering for critically ill children until they are discharged home.
Can you tell us a bit more on how the implementation of ETAT, that emergency triage, assessment, and treatment concept of WHO, with your critical care training, had an impact on patient circuit, on patient flow within your facility, starting from triage, the emergency department, and so forth?
Yes, so thank you, Hans. Before this time, actually, since we launched the free healthcare initiative in 2010, there are a lot of cases. Of course, you heard from the statistics that I told you of, that we have a lot of cases visiting our facility to access care. So by then, nurses or health workers had limited knowledge in terms of triaging these cases, categorizing them into emergency, priority, and then non-urgent cases. So, but with the advent of emergency triage and assessment and treatment training, even if we are still having a lot of cases visiting our facility, we are able to categorize them into emergency cases that need immediate attention, and then also the priority cases and non-urgent cases, and then sending them to the various units. And also for conveying of cases from the emergency unit after they have been stabilized, thanks to partners also, they brought in the ideology of using a trolley and our emergency kits in order to convey cases. Before this time, we used to hold the children, those that are on O2 support, and then rush with them up to the emergency, the HDU, that is the high dependent unit of people. But for now, after they have been stabilized, we conveying them now. We had our emergency trolley, which is a portable trolley, and then portable oxygen cylinders with the CPAP, portable CPAP machine.
So thank you very much, Sister Mara, for this important information. So implementing emergency and critical care needs more than just training. It needs a multidisciplinary approach to improve processes within a health facility, within a health system. That needs nurses, doctors, hospital logisticians, administration, and so forth. Now, let's turn back to Bukavu, to Dr. Archipe's unit in South Kivu. Dr. Archipe, could you tell us more about your training programs in Bukavu, which you have been able to carry out despite the ongoing armed conflict? And additionally, your team is actually developing specific expertise in the care of children with mpox. So please, over to you.
Thank you, Dr. Hans, for the question. So, concerning our residency program, we have for now 5 students who are doing their specialization in pediatrics. We have also a program related to nurse education. So now to face to the situation for now, as you know, the eastern part of Democratic Republic of Congo is facing on different epidemics. As you know, now we are running after mpox epidemic, which is very, very critical. And few months ago, we had also Ebola viruses, and we had also measles epidemics. So one of the characteristics of our region is to have a lot of kind of epidemics, which led us to have or to need a strength center for the management of epidemics when the national Ministry of Health could help and to try to run that kind of system. For the education, our residents, they are doing, rounds in different sub-unity of pediatrics, emergency and malnutrition and critical care and also outpatients. But we try to have a connection with other hospitals or other specialists in different places.
So thank you very much, Dr. Archipe, for this description of your residence program. Can you tell us a bit more about the conditions and clinical care residents are exposed to in your emergency department?
Thank you for the question. So I can say one of the most cases that they are facing on, we have severe respiratory distress. That's a very common one. And now we have, especially in cases of mpox, with some upper airways obstructions caused by some kind of secretion due to mpox viruses and some kind of lymph nodes. Either we have some hemodynamic instability among some cases when they have severe bacterial infections, and also severe cases of malaria, which is very endemic in our region. Malnutrition is also one of the common disease in our hospital. And also we have a problem of the blood transfusions, and that is the most usually cases. Even that, more than that one, we have also a wounded patient by the war. For now, we receive a high number of patients related to the war, and some of them they have the psychological traumatism, and also some of them they need emergency surgery. So by that, we are trying to do our best to assist those people when we don't have the governmental assistance, because we don't have healthcare system which is supported by the government. Each patient who come in need to pay for his management. That is very, very hard for patients when we are in the war and they don't have any kind of assistance.
Let's come back to the support of displaced populations. So since the M23 rebel movement is active in Eastern Congo, the United Nations estimated that more than 500,000 people have been displaced only since the beginning of 2025. Can you highlight which challenges these particularly vulnerable populations face in your province?
Okay, good. Thank you. I can highlight 4 points. I mean, direct exposure to violence that could affect children, young adults, and old men. We have what psychological trauma and disruption of family and social network. Inadequate access to clean water, food, and vector control, and severe limitation access to essential healthcare service, including pediatrics and maternal critical care, as well as vital disease prevention measures.
You clearly outlined that displaced populations are facing particular, and especially in the context of an mpox epidemic. In order to provide essential critical care in this context, access to medical oxygen is vital. Whether it's for treating severely ill children, supporting pregnant mothers with complications, managing trauma cases, or ensuring safe surgery and anesthesia. Oxygen concentrators provide a pragmatic option for decentralized oxygen supply. Could you tell us briefly how many oxygen concentrators do you have in your hospital? For the operating theater, for the emergency department, the pediatric unit, and your mpox treatment unit?
Thank you, Dr. Hans. This is one of the very complicated situations that we have for now. Oxygen access. For now, we have only 5 oxygen concentrators, and that must help the emergency room, theaters, and mpox unit, neonatology, and also for pediatric intensive care. Also, the electricity is one of the challenge because to run also our generator, we need gasoline, and when you don't have the governmental support for that, either for the ambulance that should go to pick up some patients, if they call for the ambulance, they need to pay for that, which is very complicated when you are in the war.
Thank you very much, Dr. Archipel. So providing essential pediatric critical care in a conflict zone and an ongoing mpox epidemic is incredibly challenging. And of course, you need clinical training, medical guidelines, and all that. But to deliver essential pediatric critical care, we also need to strengthen health systems. That means investing in infrastructure, medical supply chains, and others. All this can only work if the conflict in Eastern DR Congo comes to an end. So thank you again, Dr. Archipe. Now let's move to Madagascar again. Prof. Diavulana, could you share with us how your team is implementing training programs in your Centre Hospitalier Universitaire in Mahajanga, but particularly also in other regions in Madagascar? For example, in the region of Alaotromangoro, which is just east of the capital, Antananarivo. Over to you.
In terms of capacity building, we developed several university diploma programs for both nurses and doctors, including diplomas in pediatrics and emergency care, and also in neonatology. In addition, for more than 30 years, Madagascar has had a national specialization system across various medical disciplines, including pediatric. These specialization programs often include external. We have to send the resident for external fellowships, especially in France, but it could be in Canada, and myself, I was in Germany. And this provide valuable training opportunities for young professionals to gain experience abroad. However, in recent years, more and more of our doctors have been accepted to stay and practice, especially in France or in Mayotte, next door, after their fellowships. And this is becoming a serious challenge for us. It's a classic case of brain drain. So the Ministry of Health and our universities are trying to reverse this trend by improving opportunities for health professionals in Madagascar, for instance, by expanding research opportunities. But salaries need to be improved too, to make staying more attractive. And this requires funding. And that remains quite difficult in the current economic climate, especially with the impact of global trade instability and international tariff challenges.
Sister Mara mentioned WHO's ETAT, Emergency Triage Assessment and Treatment Program, and training in essential pediatric critical care. Prof. Diavulana, can you share your experience with implementing ETAT and essential critical care training in Madagascar? How has training contributed to strengthening the capacity of nurses, general practitioners, and pediatricians who provide this essential emergency and critical care? Over to you.
Thank you. Madagascar is a very large island, and one of our major challenges is that many patients during especially from rural areas during rainy season, we have difficulties to access health facilities. During the past few years, we've guided by the Malagasy medical schools and the Société de Pediatrie de Madagascar, Société Pediatrique de Madagascar, with support from partners like GIZ, USAID, and also from France and Germany. We did this training of trainers, and also we have done like a follow-up with neonatal and pediatric staff, involving our stakeholders from the pediatric areas in our region to improve the health of very sick children.
Can you describe some key elements of this training and how this training of trainer program worked? How you integrated regional and district health management teams, hospital directors, but also communities?
Thank you, Hans, for this concrete example. coming from the Lotomongo region, home to about 1 million people in that region, which includes 1 regional and 3 district hospitals, plus several peripheral health centers. We implemented the 2-year training of trainers program. The aim was to build capacity among both nurses and doctors in ITAT and essential critical care, including rational oxygen use and the introduction of bubble CPAP for newborns and young children at hospital level. We used a variety of methods, including online modules, on-site training, and on-the-job mentoring, all tailored to individual learning needs. At the same time, we're in a parallel TOT track to ensure long-term sustainability. So crucially, this work was done in full collaboration with the Ministry of Health, as well as with the regional and district health authorities and hospital directors, who all actively supported the training team. We also made sure that local communities were informed and engaged. We had amazing young nurses and doctors who are now driving these trainings forward. So another important aspect of the program was the evaluation of health facility readiness. This included training some hospital technicians in basic biomedical skills, such as the maintenance of oxygen concentrators and bubble CPAP systems and the monitoring electricity systems. These evaluations revealed major bottlenecks similar to what we've heard from Sierra Leone. So our priority is now the supply chain, and the Ministry of Health improve this supply chain for essential items by putting in place solar system energy. But it is needs funds. So we are going on this way.
Regarding the content of ETAC training in essential peds critical care, how would you describe the link to maternal care? How important is it to combine and link child health and maternal health programs?
Thank you. It's a very important theme because we, especially in the Société Monégasque de Pediatric, we worked all the time together with in the field of the family directory in the Ministry of Health. So we're not only working for pediatric in the pediatric area, but also working with the mother-child health. And one of the priority of the Ministry of Health now is this combined maternal and child health, especially reducing mother mortality as the neonatal mortality. And we developed collaboration and monitoring of this collaboration in the neonatal staff in our region, where all stakeholders involved in mother-child health are discussing every 2 months, finding the bottleneck and searching together solutions. And it is also more important in the time now that there is increasing HIV infection in the field of prevention of mother-child transmission of HIV, not only HIV, but also for syphilis and hepatitis B. So this collaboration and this action, not only in the critically ill children and neonates, but also working together for the critically ill or against maternal hemorrhage, postpartum hemorrhage, and so on, to reduce maternal mortality.
Okay, so thank you very much for these descriptions of challenges and experiences from Sierra Leone, the Democratic Republic of Congo, and Madagascar. Thanks to all our speakers. Sister Mara from Sierra Leone, Dr. Archipe from Bukavu, South Kivu in Congo, and Prof. Diavolana from Madagascar. Thanks to our colleagues from the World Federation of Pediatric Intensive and Critical Care Society. And a special thanks to the team of OPENPediatrics, associated with Boston Children's Hospital, for their support to record this podcast. For more information and relevant links, please check the show notes which are associated with this podcast. Thank you.